Let me welcome everybody to the Democratic Party Central Committee meeting. This evening we have a great presentation by Dr. Kress, who is a long-time physician here in Missoula. He is one of the movers behind a great organization called Compassionate Choices. It's a really important issue for our aging population and for others who struggle with what is the most profound question in life, which is death. So with that, let me turn over to Dr. Kress.
Okay, thanks, appreciate it. Yeah. Well, thank you for having me. First of all, one thing I want to mention is that explain that as a physician, I am personally a product of society's investments. And one thing I like to mention is that I went to, I'm a Missoula native. I went to Lewis and Clark grade school, Sentinel High School, University of Montana. Then I went through the WWAMI program, which is a lot of taxpayers in Montana kicked in money for me to go to med school, and I appreciate that. And then I did a 3-year residency in Spokane, and then after that I came back to Missoula and practiced for going on 27, 28 years. I'm getting to be one of the older physicians in town. But at any rate, I just want to, one of the things when I did give testimony before the Senate Judiciary Committee, I wanted to emphasize the fact that I am a product of government, and that I appreciate that, and that you could even probably call me, you know, a government parasite, because over half my patients are Medicare now, and I make my living on this. So when I saw in the paper that Mr. French was up in Superior and works as a lab tech in the hospital and is angry at government, and I thought to myself, well, he's also making money off government because that hospital wouldn't be open. But I want you to know that I understand and appreciate what government has done for me, and what it's also done for my patients, because it's allowed them to get care. And you know, doctors. My dad was a physician that practiced before Medicare. And he had several pack saddles, patient-made saddles for a living, and they gave him a couple pack saddles, which he never used and gave away, you know, 20 years later. And you can only eat so much chicken before you're pretty sick of chickens, you know. And Medicare pays doctors money, and so does Medicaid. And so you got to have a little bit of that too, or you wouldn't survive as a physician. So I just wanted to point out that I appreciate what government has done for me and what it continues to do for me, and then in 10 years or so, what it'll also do for me when I'm on the receiving end of health care and Medicare and things. So at any rate, I do want to say that the experience of going through the Senate Judiciary Committee and fighting House Bill 505 kind of got me involved in aid in dying movement on a more public level, and as somebody who is talking about their experience as a physician prescribing aid in dying. I certainly would probably be not public about it if somebody hadn't sort of taken a run at physicians who would consider prescribing aid in dying. And so it's one of those things. It was when this process came about, I felt that I had to kind of tell my story of what happened, and I would hope that have a lot of you kind of seen my Senate Judiciary Committee testimony, or not everybody? Okay, so basically what I did during that testimony, and in concert with Senator Barrett and others from Compassionate Choices, is I told my story of how I have treated 3 patients that requested of me to prescribe aid in dying medication. And I've probably, and I did this through my experience as being a medical director for a hospice and also taking care of, my personal patients that are on hospice. So what happened was, obviously the Baxter decision happened in around 2010, if I'm not mistaken, right? Is that correct?
2000, just at the end of 2008.
2008, 2009. So, yeah, and then for a long time, I think I sort of thought about it, but didn't really have a patient that was really requesting it, asking me to utilize this or give them that opportunity to use. And then as time went on, I met a patient through hospice that had advanced ALS or Lou Gehrig's disease, where, as you know, they lose the ability to swallow, the ability to walk, eventually the ability to breathe, and they die of usually a combination of starvation and suffocation, or respiratory failure, however you want to call that. So he was a very powerful man in his day, very successful businessman and professional, and also very engaged in his outside vocational activities. And he knew that he'd had enough of this disease. He was very clear about it, and he came to me and wanted me to prescribe him aid in dying, which would involve ingesting a medication and ending his life somewhat before his disease would take him, because he wanted to relieve his suffering. And he was very insistent on getting it. I was somewhat open to doing it, but it was a complicated decision to go ahead and do this. For one thing, I think, and I tell this to any physician, no physician really wants to be thrown in jail, or I really don't want to do something illegal. So the first thing I had to do was convince myself this was legal, because there is a group called the Montanans Against Physician-Assisted Suicide that sends letters every 6 months to all physicians in the state of Montana, and they basically say this is not legal, it's illegal. So I had to talk to people that are experts on this issue, like Senator Barrett and Mark Connell, who prosecuted the case before the Supreme Court. And I had to spend, a couple hours figuring out, is this legal? Will I be thrown in jail? They convinced me that it was. And then the next thing to do was to investigate the medications, how to get them in. They're not normal medications people would have laying around the pharmacy. You'd have to order them in special. They're expensive, $1,000 to $2,000. Like I say, most pharmacies would never have this on the shelf of their pharmacy, so you have to kind of work with a pharmacist carefully. So anyway, that process took time, and this wasn't fast enough for this man, and he eventually stockpiled enough of his narcotic medications, and he took them through his tube feeding and ended his life. He also, during the process, was made me obviously examine the whole issue of aid in dying in a more careful way, and got me off my rear end to sort of investigate all these details of prescribing it. So that even though I didn't prescribe it, I felt bad that I'd maybe failed him, and he had called me a coward on several occasions as well, and meant it. So at any rate, I got through the process of figuring out how I would do this, how it should happen, the legality of it, with his pushing. So it was a patient-generated, educational process for me. Then about 6 months later, I had a patient who developed esophageal cancer. He was a man who was more of a person who lived a very simple life. He was late 60s, early 70s, and he had not made a lot of money. This other gentleman had made a very good living. But he was also very clear-cut about what he wanted to do, that he did not want to linger and suffer. He wanted to have control over his end-of-life situation. and that he clearly was not depressed. He didn't want to die. He wanted to live, but hey, he had esophageal cancer, and he actually was somebody who chose not to have it operated on, whereas initially, if he would have, it could have been curable, but he chose not to, which I believe is something that's sort of guaranteed under the rights of the terminally ill, I believe, right, Dick? So he made that choice. And then eventually the cancer began to erode into his esophagus. We talked numerous times over the period of months, actually, and I was convinced and reassured that he was, number one, he had a terminal disease. Number two, he was of sound mind. He wasn't psychotic or anything, and he was fully aware of his decisions. And then I wrote him a prescription. After he didn't use it right away, he waited, approximately a month, and then he could feel that his chest was, he was feeling pain, and he could feel that things were becoming harder to swallow. So he felt that he would not be able to ingest things in a short period of time. So he finally elected to take the medication, and I'd become. We'd seen each other 8 to 10 times. He'd seen the hospice personnel numerous times. He was on very congenial terms with everybody. We developed a relationship. He asked us to be at his death, and so we came to his death when he ingested the medicine, and we observed him taking the medicine. He basically mixed the medicine with cherry syrup and some water into about I would say 6-ounce solution. And then he also was he was a real fan of Guinness. He asked us to join him in a toast of Guinness before he took the medicine, and we obliged him and did that. And then he sat in a chair, ingested the medicine, and then in approximately 1 or 2 minutes, he was sound asleep, and he just leaned back quietly into the chair. His head was supported with the chair, so it was a very kind of peaceful laying back. And then he breathed quietly for probably 5 or 6 minutes, and then he had a few longer breaths where he would breathe like once a minute for a few minutes, and then his breathing stopped. And then we monitored his heart rate for approximately, we monitored his heart rate every couple minutes during that time, and in approximately 12 minutes, he had no heart sounds and we could not feel a pulse. And then we continued to observe him to verify that he had deceased for probably a half hour. And then we called the mortuary service and things like that. It was, I know that all of us present at his death were very moved at how peaceful it was, and how he felt very supported at that time in his life. And his sister was there, a hospice nurse was there, a hospice social worker was there, and I was there, and we'd all become, close during this process. Many times in medicine, I enjoy seeing people once a year for a physical and they're healthy. That's great. I love that. But I also like when you deal with somebody on this level, you get to know people at a deeper level. And I also appreciate that. And so this for me was a moving experience personally as well as professionally. And so it's stuck with me in a positive way for a long time, and will probably forever till I take my last breath. And I admire this man for his courage. And one of the things he said before he took the medicine was, anything you can use from my experience with aid in dying to further this availability to other people, I hope you will utilize. So I think by talking to you about his experience, I'm doing what he asked me to do, and I'm glad to do it. So after that, and one of the things I remember, the hospice nurse that was there, she was very, 10 years in the hospice world, being at people's houses when they die, much more than I've been, because she's the one that gets called at 3 in the morning when people are dying and they need help and so forth. I've been there too, but she's there 10 times for every one time, or probably 100 times, maybe 50 times for every time I'm there. So she's the true pro on how people die. And I would say the hospice nurses are those people. She said, she just was amazed at how peaceful this was, and how what a calm and peaceful death it was. So, at any rate, since that time, I've had 3 other patients for which I've written this prescription for. I've been present at the death of one other patient, and he was a gentleman who had pancreatic cancer and also died similarly very peacefully. As you know, we had a legislative battle over this last spring. And the issue was, first of all, Senator Barrett and company took forward a bill that would legislate a legislative framework for prescribing aid in dying, would define what it is, how you do it, etc. Somewhat very similar to what happens in Oregon. Am I correct on that? Yeah, okay. So if I say something wrong about that, Senator Barrett's the expert on that, I'm not. I was sort of in the wings, not really coming out about the whole issue until somebody said, Dr. Kress, you might go to the big house if you don't get off your rear end and get over here. And, we have to take this message to a group of people that wants to put doctors like you in jail, not only doctors, but nurses and family members who help out with aid in dying. That was what the bill said. So it wasn't just me, it was going to be a lot of people sharing the same cell together, I guess, and cutting checks for 50. That was the bill put forward by the Montanans Against Physician-Assisted Suicide. And so we mounted a campaign which was very successful. I came out on this issue, Senator Barrett spoke at it, Doris Fisher, Bob Baxter's daughter, a number of people came and talked to the Senate Judiciary Committee. And like a lot of things that happen in the legislature, there are things that are kind of going to be, quid pro quo. I vote for this for you, you vote for this for me, we all go back and drink scotch and celebrate our victories. So it was sort of predicted that this would be a partisan issue, that Democrats would vote against it and Republicans would vote for it, and it would just move through the Senate Judiciary Committee, and then it would get to the floor, very likely, and then we hopefully have a governor that might veto it. But what happened was, it was really something that brought faith back to me about our government. We as you know, we worry about our government. Is it functional? Are we able to compromise on differences that we have and make government work? Even though obviously there's some strongly felt differences, but can we make it work for people? But at this day and with that vote, government worked. People listened to the issue. They decided, should government, there is a role for government to decide things. Government decides, when somebody should have a speeding ticket, when, the government decided, you should wear a seatbelt. Government decides that, okay, if you murder somebody, you should pay. And government, I understand that government has a role to decide these things, but now we're looking at, should government interfere with a doctor and a patient in this role that might be played? And government in Montana through the Montana Supreme Court, has decided that this is reasonable and legal for a doctor and patient to discuss this and for a doctor to write this prescription. It would be nice if we had legislative efforts that succeed that also define this, but that many Republicans on that committee looked at the issue and decided we're sort of the anti-government party. We should not vote to have a government intrusion into this part of somebody's life or death. And so I think in that way it was an issue where people took off their partisan hats and they listened to the issue and they voted on what they thought was right for the citizens of Montana. And it was basically tabled in committee and then blasted out, and then on the floor of the Senate it was voted down. And so that, to me, is something that should give us hope that government will work well for us, and also that people are open-minded. They would think about things not just from a partisan lens, but from what's best for Montanans. So that whole process was one that I appreciated what government did on that day and in that time. A couple things I want to talk about with aid in dying today too is, first of all, I wanted to say that aid in dying is just that. It's aid in the dying process. The term suicide connotes a tragedy that occurs all too often and in a very sad fashion, and it's by somebody who wants to kill themselves, that they've decided that life is so miserable that they can't go on, and they want to die. But everybody I've prescribed these medicines to did not want to die. They wanted to live. They actually were leading great lives that they really enjoyed and were very full until their terminal disease took that away from them. And they were going to die. It was a question of, weeks to months at the most. And so these are not people who wanted to die. They wanted to live. And I think that, today we read in the paper that more Vietnam veterans have committed suicide than ever died in the war. And that's such a tragedy. And I think that's so different from what this is about. This is about helping somebody through the dying process. These are also people that have lived much longer lives because of modern medicine. When you got ALS 100 years ago, 200 years ago, you didn't live 3 to 5 years. You died in the first year or two. Now people get tube feeding, they get antibiotics, they have assistance through all sorts of things, and they live much longer with a terminal disease. You all know people with cancer who fought it for 10, 15 years. Those people would have been they only developed safe surgery till the middle, with anesthesia during the mid-1800s. Anybody who got breast cancer in that time, it was an automatic death sentence. People with breast cancer now often cure it, and then if they don't cure it, they often fight it for 10 or 15 years. Then they might be subjected to a pretty miserable death at the very end, but they've fought it for so long. Lung cancer, same way. So I think that people are living much longer with terminal diseases that we can't really call it a natural death. It's an unnaturally slow, long death that most of us are going to, when we have a terminal disease, are going to say, I want to fight this thing, I want to beat it. Sometimes we will beat it, sometimes we won't. And even if we don't beat it, we'll live a lot longer, but we might suffer way more than we ever would have suffered at any other time in history. So if you want to, I don't consider it somebody giving up when they use this option. I consider it somebody who fought a very long, hard battle, and they're not going to win it. I mean, I don't necessarily think we should look at it as a battle all the time, because we are all going to die. We're all going to lose if we look at it that way. And often their terminal decline is also full of really great moments for that person and their family. I know one thing I always tell people, a lot of people say, well, I just want to, keel over dead, but from what I've experienced through being a hospice medical director and seeing what happens to people, I would never want that to happen. I want to know I'm going to die in a year or two. I want to connect with all the people that have helped me and my loved ones, and I want that to happen. I've seen so many good things in my own life and other people's lives when they have some time to address those issues. It's harder when you have somebody who slips away with dementia, and then you can't really at that time bring up those issues in a really great way. And it's also harder when you have somebody who just keels over dead of a heart attack, and you might have just gotten in a fight with them last week and called them a jerk or whatever, and not had a good experience. So I do think that having some time to deal with these issues is something that we can all benefit from many times. So I kind of talked a little bit about the natural death issue. I don't think we have that many natural deaths. Most of us use antibiotics, we use immunizations. We're not going to die naturally. We're going to live unnaturally long, which is a good thing. None of us want to just be subjected to the ravages of nature in its raw, unfiltered state. It's a pretty rough way to go. And I guess one of the things I want to, one of the things that when I talk about this, I think it's been, I want to make sure it's not too much about me, because it's really about the people, the patients that deal with these diseases, and that I think we should be motivated for. And these patients are the people that got me where I needed to be. They taught me very powerful lessons. And I was at a talk the other night, and two people came up to me, and they had two very moving stories for me. One was by a gentleman who told about his friend that was diagnosed with terminal cancer, and he talked about how he didn't want to suffer and linger and things, and he basically went out with his shotgun. And he apparently was a very safe hunter, would always unload his shotgun before climbing through a fence, that sort of thing, would never take a risk, getting through a fence. At any rate, he was found with with a gunshot wound to the chest, climbing through a fence, theoretically, and his death was listed as an accident. But in reality, this person strongly believes he basically shot himself in the chest is a way to end his suffering, and also to not spare his family the whole process of that dying. Another person came up to me and talked about a woman, it was a woman, and she talked about her friend who had a terminal cancer diagnosis, and she ingested antifreeze and died using that. I don't know what that would be like, but it is pretty toxic, and dogs love it. So, I mean, most vets will tell you that, hey, don't let your dog get near antifreeze, because they drink a bowl of that and they apparently really like it, and they're pretty much goners. Antifreeze can be very toxic. So, at any rate, these are people that motivate me. That also, I've met with a number of physicians who had a colleague up in the Kalispell area that killed himself with a shotgun, and because he was in the process of dying, and really didn't feel that he had another way to deal with it. And so they've become very motivated about being involved in this issue too, to avoid people having to resort to that. So at any rate, I want to thank you for listening to my stories, and I would entertain any questions at this point. Mm-hmm.
About, life insurance. People that have life insurance, for instance, the only person I would have that would be my son. And I want him to have enough, the hospital, I would have to have that burden, So if you have life insurance, then what do you do? That would make sense.
There are a couple things. One of the things is when somebody dies who's on hospice, and let's say we put down whatever their underlying diagnosis is. And so this gentleman, I put on his death certificate, he died of esophageal cancer. He didn't die of, I mean, he didn't die of pentobarbital poisoning. He really died of esophageal cancer. Likewise with ALS, you don't put down pentobarbital overdose, nor do you put down morphine overdose if somebody used morphine, or if sometimes we use terminal sedation, say with propofol, which is what Michael Jackson was utilized when he was put to sleep at home and then died. We don't put down propofol overdose on somebody who's terminal with a terminal disease. We put down that they died of their disease process, which is really an accurate description. That is actually mandated by law, I believe, in Oregon because of that issue, that we don't really consider this suicide, and it's really palliative care at the end of life. And that's what I do think that I do when I talk to other physicians about doing this. I think there has to be some understanding of that process, that could complicate things if you didn't fill it out properly. And you know, that's one thing I do talk about. But I think it's also true that written on the death certificate form, they don't want to have, say, cardiac arrest on the form. They want to have coronary artery disease that caused the cardiac arrest. So when somebody, even if they drop over suddenly of a heart attack, you don't put down cardiac arrest, that just means the heart stopped. You actually put down coronary artery disease. They want the underlying disease condition. There are many things that can cause a cardiac arrest. The underlying disease process that cause that would be coronary artery disease or pulmonary embolus or renal failure or something like that cause the cardiac arrest. So does that make sense? Yeah. So actually when you fill out a death certificate, if you're doing your due diligence, you should fill out the underlying disease that caused the death. Any other questions?
Eric, I'm sorry, was your question about licensure?
No, it's like life insurance.
Life insurance, yeah. Mm-hmm. Yeah. And yeah, so I think that's why I say and one of the things we work on tirelessly on this issue is to call it aid in dying and not to call it physician-assisted suicide. It's also not euthanasia. Euthanasia involves deciding somebody else's situation, say your pet. Euthanasia would also be an accurate description of what might take place if somebody were to decide that somebody with dementia should be, given the medication. That is not what we're talking about here. The person has to be of sound mind, and they have to be able to self-administer the medication. So those are two very key things. And they don't really apply to dementing illnesses, cognitive illnesses that rob your ability to effectively make decisions. And I go through a very specific process of analyzing people to make sure they are cognitively there. And it's not something that I really want to take a chance with somebody who's even borderline cognitively functioning. Mm-hmm.
What do you think is the biggest priority right now for aid in dying movement? Is it informing physicians of the legalities that you had to, so that others don't have to do what you did, or is it enacting legislation like Senator Barrett has proposed, or is it fighting, sort of the folks who are opponents of this whole thing? Where do you see the priorities lying?
Well, basically, the next legislative session is probably going to be a broken record of this last one. So we fully anticipate that pro-aid in dying factions will propose legislation that will define aid in dying, like Oregon has, like Washington has, like Vermont has now, and like other states are looking at. So we do think that would be a better situation overall, if I'm not mistaken, Senator Barrett, because you're the kind of the person that...
Go ahead.
Okay. Then the second thing is we fully anticipate that somebody will take a run at sort of defining aid in dying as illegal. So in that sense, I think it will be sort of like a broken record, that will probably have similar things happen again, and that will be called upon to both support legislation that we think would do a good job of defining aid in dying legislatively, and that will, if that doesn't work, then we'll again be called upon to defeat legislation that would define it as illegal and throw doctors in jail, etc. So I think in that sense, we are, the folks I work with, and I would point out Compassion and Choices here, is an organization that works on a lot of end-of-life issues, not just this one by any means, but they work on a lot of end-of-life issues. And if you're not a member or not familiar with them, I'd strongly encourage you to grab a magazine, sign the petition here that sort of says you support aid in dying, and learn about the issue and study it from more angles. They're working all over the country to basically support and kind of work on these issues all over. And they have greatly magnified my voice. If I was just me, Eric Kress, I would have just gone and given an okay speech in front of the Senate Judiciary Committee, and then I would have been forgotten in a lot of ways. But my message has been greatly enhanced. As you can see, we've got the letter to the editor, and then we had big ads that brought this issue to the forefront, such that when, and I think a lot of it is really explaining the issue, because when people understand, when I tell the story of these patients, people understand what's going on. When you say, well, somebody could abuse this, somebody could off their relatives, etc., then you could say, well, gosh, that's bad. We don't want somebody to off their relative. But we have to look at the positive side of this issue of what are, how we can benefit people and how patients that are totally appropriate have gotten it. And in my case, I can guarantee you that nobody inappropriate has gotten it. It's sort of like the issue of, sure, I write prescriptions every day that could be used to kill people, or people kill themselves. And so it's not an uncommon experience for any physician to write a prescription that, if ingested improperly, would kill them. And so I think we have to, it would be an instrument of potential abuse or potential suicide. So this is a medicine that I more carefully than any other medicine prescribe. I feel it's very unlikely somebody will use this in a bad way. And if they do use a medicine, this one or any other medicine, to kill somebody, you know what? That's murder. That's already on the books. We've got murder pretty well covered. And so I think that's why should we add another law to cover something? And if somebody gave this to somebody against their will, what would that be? Murder. And so why do we need to add more legislation to this? We need to do whatever we can to, make sure that this is used in an appropriate way, and like any medication, but there are, people can use them in ways that could hurt them. And, we try through myself and nurses and pharmacists, we try to really get people to use them in the right way. And most people do, and they greatly benefit from modern medications. But sometimes they take them in the wrong way, either intentionally or inadvertently, and that's a tragedy. So, at any rate, I think that we'll be fighting this issue again. But I do think we have a lot of people that understand the issue way better now, and understand that aid in dying is not physician-assisted suicide. It's aiding people in the dying process, and really understanding what that is. And when they do, I think it's going to be harder for people to sort of beat up on this as physicians helping people commit suicide. It's really aiding people in the dying process. So,
Senator, do you want to come up and
Well, one thing I wanted to say is, what did you say, Eric? That something about your speech? You said yours.
My Senate Judiciary Committees was just a speech, you know, an okay speech, whatever.
I have been in 3 sessions in the legislature. I've been to lots and lots of bill hearings. It was the best testimony I've ever heard in any Senate hearing or in any legislative hearing on any bill ever. It absolutely rocked the house.
Well, thank you.
So
Appreciate it.
don't be you really should go and look at it. And you can. You go to the legislative website.
With respect to the what the future is, one of the things about the Baxter decision is that it addresses criminal liability and the question of criminal liability. But the reason I asked you, I thought you were talking about licensure, is it doesn't address issues of licensure. It doesn't address issues of complaints that might be brought to the Board of Medical Examiners. It's an unsettled issue at this point what the Board of Medical Examiners might do if a complaint was brought to them about a physician, say Eric providing aid and dying to somebody. It hasn't happened yet, but the Supreme Court decision doesn't directly address those decisions on the part of the Board of Medical Examiners. It doesn't address the possibility that Eric might be subject to sanctions from an employer if he worked for the hospital. It doesn't address, there's a wide area in terms of the physician's practice that's not addressed by the Baxter decision. And that was one of the purposes of the legislation that I introduced, which was to provide additional guarantees. It doesn't explicitly address the life insurance question. There's a number of issues out there that it doesn't explicitly address. And the other side of the legislation was to try and provide some degree of comfort to people, you know, who are fearful about issues like elder abuse, who are fearful about because really the Baxter decision leaves the situation significantly more open here in Montana than it is in Oregon or Washington. Right now, it's up to Eric to decide. It's his discretion. He has to know that the person's terminally ill and mentally competent and an adult. But beyond that, he's uncomfortable. And there are people who are uncomfortable about that. And in Oregon and Washington, which have very, very similar laws, the guidelines are quite similar. And they would place restrictions on him. He would have to, for example, send a patient to another doctor for a second opinion if he was doing this in Oregon. He would have to fill out specific pieces of paper where the patient signs and says, you know, I understand, and so forth. He'd have to have witnesses for that. He'd have to refer, if he had any doubt about the person's soundness of mind, he'd have to refer them to a, which would probably do anyway. But there are no, the Oregon and Washington law specify a series of protocols with respect to how aid and dying is to be provided. The bill that I designed established some of those protocols. It's less restrictive than Washington. So it would have, if it had ever passed, ended us up somewhere between where we are right now in terms of the basically wide open situation and the situation in Oregon. Right. So that, you know, that's the kind of legislation that I think we need. As Eric says, we're going to play that record again, and you know, it has not succeeded. This is actually the third session. This last session was the third session that I brought a bill like this. And I think he's absolutely correct that we can be sure that there will be another attempt to. You didn't use this word. I would have said criminalize the provision. And that was a bill that, despite Representative Wilson's good efforts, made it through the House. And as Eric said, died in was tabled in the Senate Judiciary Committee, blasted out, and defeated on the Senate floor. And I did want to just add one last thing with respect to that, and that is, Eric mentioned that this was not a partisan issue, and that was definitely true. There were 8 Republicans in the Senate who voted against criminalization. And 2 Republicans, and I'll give them a shout out, Bruce Tudfett and Jazz Vincent, made eloquent and impassioned speeches against the bill. And I think that was influential in probably turning some of those Republican votes. And there were Democrats who voted for criminalization on the floor of the Senate. So it is bipartisan. And from a political point of view, that is from a philosophical political point of view, it was a question of liberty. It was a question of leaving people to make decisions about the end of their lives with their own physicians.
Yeah, so that was a gratifying part of the whole thing. And you know, I don't know, at some point it would be nice to get, there's a great piece on Reason TV, which is actually a libertarian website that has a discussion of it partly by myself, but also other players in the whole House Bill 505, including Creighton Kearns, who gives and one thing I got to say about Creighton Kearns, I honor him in terms of his honesty. And his, when people clearly say what they believe, they also get other people to sit down and look inside yourself and decide, what do you believe? What do you, and so when sometimes it's easy, I guess, to get angry over somebody you don't disagree with, but sometimes that person you're disagreeing with can make you do a better job of explaining your side of the issue. And certainly he made me sit down and really think about this. And it's not just me deciding to do it anymore. It's me deciding to communicate with society about what I did at this time, and that it was a good thing. And I would do it again. And I'm glad it's legal. And it should be preserved as a legal process. And I think the fact that this bill was put forward and then we responded to it in a way that I think greatly strengthens the chance that aid in dying will be seen for what it is, aiding people in the dying process and not suicide. So in a sense, society was educated a lot on this issue through this process. And it was, you know, certainly part of it was me, part of it was Senator Barrett, but a lot of it was Compassion and Choices and their echo chamber of newspaper ads and talking to other people that believe in this. They know people in Bozeman and Great Falls and Billings and all over the state and Kalispell that believe in this issue, and they got them to write letters too, and they all, you know, there's also polls that show that the vast majority, you know, 70 to 80% of Montanans support this now, and I think it's one of those things that, you know, we have to use that energy and take it forward, and we're not saying to anybody that you should do this, we're just saying you should have the option of doing it, so. Okay.
Okay, well, thank you. Let me join me.
Okay, thank you, appreciate it. Thank you.
We'll take a short break.